again, I'm Mary Hale. I am the Behavioral Health Director for Orange County and the president of CBHDA. So far today, we've heard from the state, we've heard folks from the national perspective, just heard from providers, and now we get to hear from those folks who will really tell us what's needed, those individuals who are family members, themselves living with behavioral health disorders or representing communities that do so. So the panel to focus on stakeholders, families, and clients. Really important information. I am going to give them more time to speak. So I'll tell you a little bit just about who they are, their name, and their organization. Then I'll go sit down so you can actually hear from them. And we'll go in order. This first person here, Mr. Steve Pitman, actually is from my county, so I happen to know Steve. Steve is the president of NAMI OC and has just recently, I think in July, been elected to the board of the national board for NAMI. So we are very fortunate to have him in Orange County and then here today with us. We also have Linda Naranjo, who is a peer support specialist with NAMI San Diego. So I think actually everyone else is local here to San Diego. So Alfredo, you've done good. We have Daphne Watson, who is the executive director of MHA, Mental Health America of San Diego. Followed by Rebecca Hedman, who is a parent partner with the San Diego Center for Children RAP Works program. And our final speaker on this topic today will be Melissa Jimenez. She is here? She's here. I'm like, I talked to her before we started, but so I hopefully said her name correct. It's spelled incorrect in your programs, but when she comes up, she'll set you all straight. Melissa is an employment specialist with mental health systems and is a member of North Coastal NAMI here in San Diego. So with that, I will turn it over to Mr. Pitman. Steve.
I used to be a school principal and everybody called me Mr. Pitman, so when they say that, it kind of harkens me back to days long since left. I've been sitting here all day listening to these presentations, and I can't tell you how impressed I am. I couldn't, these issues that you're dealing with are far too complicated for me. My message is a much simpler one, so hopefully this will be a respite from that hard intellectual exercise you've been going through. I want to be clear in beginning that when I refer to the system, either directly or obliquely, I'm referring to the public and the private healthcare system. I do not think one is appreciably better or worse than the other. I do think that change is more likely to occur in the public system than in the private system, but that's my opinion. My brother John died almost 3 years ago. John was the oldest of 6 children. Intellectually, John was very gifted. He lived with schizoaffective disorder for the last 50 years of his life. In the early years of his diagnosis, John held low-wage jobs. He started and later finished college. He owned a home. He married, and he had children. As John's illness progressed, he lost each of his jobs. He divorced. He became estranged from his children and largely estranged from the family of his birth. Although John always wanted to work, it became more and more difficult for him to gain or keep a job. While the exact number of 5150s is a little clouded, 100 is a reasonable estimate. John was hospitalized for the last 6 weeks of his life. For all intents and purposes, he was asleep and completely unresponsive. He resisted all attempts to treat him. IVs, PICC lines, catheters, feeding tubes, etc. At one point, in desperation, I tried to wake him up, and after a while, his eyes began to flutter, and I asked him, I said, "John, do you want to die?" And John shrugged his shoulders. During the 6 weeks John spent in the hospital, he had 3 visitors: his mother, his daughter that he hadn't seen for 20 years, and me. Although there were those that loved John They loved him from a great distance, both literally and figuratively. John died alone. He was disconnected. John had lost all hope. Our mother flew in for the funeral. My sister conducted the service, and before she began, she came over to speak to my mom. And for some reason, I turned around and looked back into the chapel, and to my amazement, it was full. My first thought that John would have been surprised to see so many of his family and old friends, and that he would have been pleased. My second thought, which went unexpressed, was, where were you when he needed you? That's the story of John. Now let me tell you about my granddaughter. Sorry, folks, there's no other way this ever comes out. I apologize. Let me tell you about my granddaughter, Melissa. Melissa and 3 siblings moved in with my wife and me 22 years ago for 2 or 3 months. They are with me still. When Melissa was a junior in high school, we discovered she'd been sexually abused by her biological father. Within 5 days of her disclosure, her father had committed suicide. The trauma of the sexual molestation and the death of her father threw Melissa into a tailspin. Melissa was diagnosed with bipolar disorder. In the first 8 years of Melissa's diagnosis, she was locked up in a psychiatric unit 40 days per year. She turned 16 in a psychiatric unit. She graduated from high school in a psychiatric unit. Subsequently, Melissa has completed her undergraduate degree, lived independently, had committed relationships, supported herself financially, and enrolled in graduate school. She has taught NAMI classes for families and for those living with mental illness. She's led support groups for families and those living with mental illness. She has spoken to many groups regarding her experiences. Melissa died in April as a result of a blood clotting disorder. So here we have 2 people, both living with a serious mental illness. Both were challenged. One flourished and one didn't. Why not? John's first psychiatrist concluded within 15 minutes that his problems were directly a result of my mother, my father, and the dysfunctional family in which John lived. They were told to get out of his life. Do not have John in your home. Do not go to his. Meet him in parks and restaurants, neutral places. My parents followed those instructions and considered putting the other 5 children up for adoptions. Not an unreasonable response, given that the psychiatrist had told them that they were the cause of all of these problems in the son they loved so very much. Now, I want to be clear, my family wasn't perfect, but my parents were both ministers. When they retired, they enrolled in graduate school and got marriage and family counseling licenses to better understand John's mental illness. From the outset, Melissa's grandmother and I participated in the selection of her therapist and her psychiatrist. From the outset, we communicated with them. We knew her diagnosis, we knew what meds she was on, we knew what she was working on in therapy, and we knew what we needed to do to support her. We did not know, nor did we feel any need to know, her deepest, darkest secrets. And frankly, we had no interest in Melissa knowing our deepest, darkest secret. We wanted to know, as her parents, what do we need to do to help? That's all we cared about. When Melissa turned 18, she could have excluded us from the therapeutic process. She didn't. John's family did not discuss mental illness. At times, my siblings felt like John intruded on the energy my parents had for them. Feeling that they were in part responsible for John's mental illness, and having been told that there was nothing they could do to help, they withdrew from him. They became largely estranged. When I would talk on the phone with our siblings, John's name was rarely mentioned. Melissa's family discussed her mental illness just as they would have had she been diabetic. Melissa's siblings had as much information as they were comfortable with. They did participate in some of the therapy sessions. Her younger sister walked through the graduation line and picked up her high school diploma. John seldom spoke of his illness. Melissa would discuss hers at the drop of a hat, almost without provocation. We continue to hear from people that Melissa had helped. Families and consumers alike. Not much is said of John. Now, had we polled each of you upon entering this room as to what the most important thing in your life was, I would be willing to bet the farm that 95% of you would say, it's my family. And yet, we create a system of care, far more often than not, that shames and blames families, a system that deftly cleaves the family from the person that so desperately needs the love and support of family. We wouldn't consider doing it for any other illness, and we still do it consistently in the face of mental illness. In every other illness, the family is embraced by the medical community as support necessary to maintain hope in the face of illness. In mental illness, the presumption immediately is that the family is somehow responsible. I recognize there's a much better understanding of the biological basis for mental illness now than there was 50 years ago when my brother began his journey. But having said that, in 2015, NAMI classes in Orange County, throughout the state of California, throughout the United States, continue to be full of parents who are still being blamed for the mental illness in their family member. Is it any wonder that they would withdraw eventually? Let us set aside my complete conviction that those suffering will do better with the support involvement of their family. Let us consider the involvement of family from the standpoint of an available yet little used resource. And as I sat here today, resources came up again and again and again and again. Now, I don't want to go down the road of we treat people that have no families. I hear that all the time. Well, this person doesn't have family. I don't get that. Never have. Everyone has a family. The system may have driven the family away. The family may have withdrawn because they didn't understand mental illness, but everyone has a family. A mother, a father, perhaps a sister or brother, a grandparent, perhaps, but a family. If the only thing you did was begin a program to educate that lone remaining family member, and I suspect you'll find far more than just one, if the only thing you did was introduce that family member to the support networks for families, if the only thing you did was to teach that family member how to advocate for their family member, your client, the results would be overwhelming. First, you would be creating a support person that will be on the job far longer and more intensively than a caseworker, than a life coach, than a therapist. These folks all get transferred, promoted, or leave the field. Family members always remain family members. Second, in California, you would be unleashing on the system almost 10 million advocates. Or if you preferred, let's just focus on those with serious mental illness. Now the number drops to 2.4 million. And that's if you only found one family member per client. Third, these folks work for free, as families always do. You need resources, you have resources. The system is not actively or consistently cultivating the family. Finally, as you all know, toward the end of the Pope's visit to the United States, he addressed the World Meeting of Families. The Catholic Church recognized that the bedrock of faith is built upon the family unit. I went to their website and reviewed all the sessions one could have attended during the multiple-day event. It quickly became clear that the family was central in all discussions, never excluded, always included. I was pleased to notice that there was not an exception to this inclusion for discussions of mental illness. Finally, I think there is a change in the wind. I discussed my comments to some family members who have experience in the public system. One mentioned her experience with the Orange County PACT program. She said the staff at the PACT program hunted her down. They wanted her to be involved. She was astonished. She says, I was a little bit suspicious at first, but I've gotten over it. So there is a lot to be hopeful about. And as somebody said at the panel discussion that preceded this one, these things are always easier to talk about than they are to do. But it's in the doing that the challenge exists. The talk is easy. But in execution, we gain power. And I think that's what we want for all of us. And it's what we want for the people we serve. Thank you. And it's my pleasure to introduce Linda Neuron.
Thank you, Steve, for sharing your story. It's really inspiring. I will be sharing a little bit about my story. I was asked by my mentor, Recovery Innovations, to speak, and I said yes, so here I am. As a young girl, I loved to read. In the 5th grade, I asked my teacher for a summer reading list. I read Island of the Blue Dolphins. In middle school, I read Anna Karenina, Gone with the Wind, and Wuthering Heights for the first time. In high school, Leo Tolstoy continued to be my favorite author. My senior year of high school, I read Wuthering Heights again, but this time not for fun or for myself. I read Wuthering Heights and wrote a thoughtful essay and could discuss its themes and symbolism in a Socratic seminar. I learned complex ideas like essentialism in high school as well. I also took a How Stressed Are You quiz in psychology class. So needless to say, I scored very high. The stress of choosing a college, something that seemed like a life-changing and defining choice, stress of finals, and stress of the holiday seasons landed me at Sharp Mesa Vista Hospital. While in the hospital, I enjoyed group therapy, hearing about others' experiences, and recreation therapy, including art therapy. I was part of a drug trial because at the time my family did not have health insurance. I stayed inpatient for 21 days, including Christmas. My second stay was voluntary. I stopped taking my medications without consulting my psychiatrist, something I do not recommend to anyone. I knew I needed help, and I called for help, got into another drug trial, and stayed this time for 17 days. Again, I did not have health insurance, this time due to a pre-existing condition, a history of mental illness. Now we have the Affordable Care Act, which regardless of whether we support it or not, gives us options. For the last few years, I have turned my focus to a vital part of recovery, volunteering and advocacy. As a clinical career extender, now known as a Pathmaker intern, I did direct patient care before coordinating many interns in the behavioral health, geriatric, psychiatric unit, and wound care units of the several Palomar Health hospitals in that system. During this time, I was going to college, but I stopped reading books for fun or for my own pleasure, and I went from a 4.0 GPA student to a 3.0 student. Struggling to sit in class or read for pleasure, I realized that perhaps other people in similar situations also could not do the activities that they once enjoyed, either because they were in the hospital or because they could not get out of bed. This did not seem right. As a leader, I coordinated projects that would bring enjoyment to people in the hospital. This was not hard. All I had to do was think, as a person once in that situation, what did I enjoy? What brought me happiness? The focus of my projects was to promote wellness and involve the community to show support for those of us working towards wellness. I helped an occupational therapist bring joy and gifts to the people during the holidays. Together with the help of many interns, I collected donations, hosted a gift wrapping party, and hospital staff were able to give 25 people in the behavioral health units a shoebox of gifts and were able to raffle off prizes. I was a team captain for NAMI walks. I directed a singing group called the CCE Entertainers, and we sung and played our instruments and also rehearsed a lot to perform songs for the seniors in the geriatric psychiatric unit. After I ended my volunteer time at Palomar Health, I worked as a personal care assistant for Palomar Supportive Home Health. I helped seniors with their day-to-day activities and provided companionship. Again, I realized what brought seniors happiness is what would bring happiness to a person of any age. A walk in the sunshine, sitting in a garden, listening to music, etc. A few years later, I got the opportunity to work with seniors again. I answered phones at Elder Law and Advocacy, a nonprofit law firm that serves seniors over 60 in San Diego County by offering free legal advice and estate planning documentation preparation. I found great joy in this work, and I was very calm, kind, and compassionate with all that called because I remembered who was on the other side of the phone, a person. In all my work, I have focused on the person. I treat all with respect and look for the strengths in each person. It's easy for me to find common ground with people because that's just it. We are all people who live through transitions and experience life. I like to crochet hats, scarves, and purses. I also crochet food, known as amigurumi. I tried to play clarinet with the same vigor that I did in middle school, and I recently finished reading a book for fun for myself after not reading for these reasons in nearly 10 years. I also bought the book, and it was not a textbook. It's called Why Not Me by Mindy Kaling. I recommend it to anybody. I do not usually tell people my diagnosis, as there are so many other unique things about me that I usually start off a conversation with. Ludwig van Beethoven was a musician. Stephen Fry is an actor and a director. Russell Brand is a comedian. Vivian Lee was an actress. Leo Tolstoy was an author. Abraham Lincoln was a president, and I, Linda, am a great coworker, supportive girlfriend, quirky sister, loving daughter, and proud puppy mom, and I live with bipolar disorder. Like all who I have named, I wish not to be remembered today by my diagnosis. That is why I spent so much time describing some of my accomplishments. What I would like to say is that there are many resources out there to find support. We need to continue the great things we all do each and every day. We need also to say thank you to one another. And I would like to take this time to say that I appreciate the state of California and this country for what it already does offer. My parents come from countries that sometimes do not recognize mental health challenges. Therefore, I am extremely grateful for the resources that exist in San Diego County. In life and at work, I witness organizations partnering with one another. I work for NAMI at the In-Home Outreach Team, a county contracted program which is a collaboration between the Union of Pan-Asia Communities and the lead organization Mental Health Systems. As a wellness advocate, I also just got a new title. So wellness advocate, I am in a unique situation to witness the current system of care in action. It seems difficult to coordinate primary physician's referrals with a psychiatrist who is available right away. Incorrect insurance billing causes needless chaos and worry for any person, especially for someone new to the behavioral health system. When barriers appear, I encourage the person who I'm working with to help focus not on what is wrong in the health system, but what is positive and what resources are available to them. I think we need to continue to work with each other to bring about change in conferences like these and more intimately at meetings with each other. I have been on the receiving end of many emails that remind us what services different organizations provide. It is hard to know everything and all the resources, but as long as we continue to make our communities aware of these services offered at wellness fairs, job fairs, 5K marathons, and by supporting each other at events, we can reduce the stigma associated with seeking help from behavioral health organizations. How great would it be to have our organizations sponsor a Humane Society's pet adoption event or promote art galleries like Art Hatch and their 24-hour artathon that supports at-risk youth and aspiring artists. If we continue to be active members in community events, then the public will see that our organizations are full of people that care and that participate in our community events. We need to continue to partner with the community and work side by side to promote wellness and support to all members of our community. Thank you for listening. I usually get dry throat, so I brought this, but I think I did good.
Good afternoon. My name is Daphne Watson, and I'm the executive director of an agency called Mental Health America in San Diego. And it's a pleasure to be here today because I am very passionate about getting quality mental health care to all people. And I'm sort of going to have my discussion sort of focuses around a different angle. It focuses around making sure that mental health care is provided to all people. You know, the California Department of Public Health, in its recent report, and it's named the Portrait of Promise, the California statewide plan to promote health and mental health equity, in its August 2015 report, it made a statement. And this is sort of a profound statement that we should all ponder today. It said, California's population is the most diverse in the continental United States and one of the most diverse in the entire world. Just think about that for a minute. Especially as we are providers or service policymakers, then the questions we should be pondering is how effective or how do we ensure that we are effective in providing the quality services to all people, to this diverse population. Recently in California, there has been a project underway called the California Reducing Disparities Project. And it began in 2009, and it really embarked on the effort to reduce the health and mental health disparities among communities of color. The key aspects of the project was to improve and increase access to care, expand quality care, and create a positive mental health outcomes for racial and ethnic cultural communities. In San Diego, it led to a program that I run. It's called Breaking Down Barriers. My program focuses on some key populations, cultural populations in San Diego. African immigrants, African Americans, Native Americans, Latinos, and the LGBT population. All of this with the goal of identifying unmet and unaddressed mental health needs within these communities. It's been an astonishing journey. It's been an eye-opening journey as we've been at this for the last 7 years. What it helped us to appreciate is how services is provided really is the key aspect of why people are not getting care. Also, a lack of understanding about the true essence of each of these communities has led to people providing the wrong kind of care or not being seen by those who need help as a resource for care. So the key things that we do in our program is really outreach and engagement. We really work within those communities, and I have staff who are representative of those particular communities. So they know the nuances, they know the language, they know the feelings that each of these individuals might have of the culture itself. Interestingly, we've learned to not lump one group of people under one heading called ethnicity. In San Diego, we have Native Americans, 21 tribes. And all of them are different. And all of them are unique. And all of them do not respond to the same thing. Even within the African American community, is such diversity. The African immigrant community is such diversity. Latino community is such diversity. Interestingly, I used to work with a program that used to be up in Santa Barbara, and we used to have Latino individuals coming into the program, and they would go through the court because that was part of the process. And the court would having a Spanish translator. But the translator didn't speak Mixteco, which is the language of the indigenous individual. So that person did not understand what was being said. And the rights of that individual wasn't being upheld. And they weren't provided the quality care that they needed. So what does that teach us? That we really have to understand really what these communities are about. We really have to have a lens that really digs deeper than just a label. That we really have to be able to provide the quality care so that we can get the outcomes that we're all hoping for. We do a lot of education and training as well, with an eye of culture, an understanding of that culture. And we equally learn what from individuals within the culture, as well as what we can provide, so that we can make sure that we're doing it right, that we're addressing real needs, because all of us working together can make a more effective approach to care. Mental health is very frightening among individuals, various cultures. Very frightened about mental health, a lack of understanding about mental health. or there's been many a story or experience that people still hold on to. I know that in the African American community that the syphilis experiments still resonate with individuals in the community, so they're frightened of mental health care. So rightly so, we have a lot of education that we have to do, because we're living in a time when it's the best time, I say to people, the best time to have mental illness, because you can get the most care, the quality care, the most least restrictive way, and become really a very happy and effective person, because there's so much care and treatment and services available. So we have to educate people. We have to really help them really understand the supports. We also have to branch out to make sure that true continuum of care exists. Prevention in its full array has to be in every community, as well as intervention and treatment services. And we have to make sure that it's available. A lot of times I hear from individuals even now, well, I called there, but they're not taking new people. Or I call there, but it's so far away I can't get to it. I call there, it doesn't seem like they understand what I'm talking about. So even though we can save there as a service, if it's not effective and accessible to people, there is no service then. We also know that from our vantage point, that home-based mental health services is a unique service that probably will make a difference in communities of color. You can go to their homes. You can see them in their environment. There's no such thing as a no-show, as well as they feel more at ease in engaging with individuals. But because our systems are not so set up for that, we sort of shy away from it. But really, we should be embracing home-based service care, really seeing people in their environment, being able to help and outreach to them, and being effective. And we build better relationships with them. We build better strategies for care, and we really engage people in effective ways. One other key point that we often find is psychiatric urgent care is one of the terms that are used in our treatment modality. We should model that off our physical urgent care models, where you can go in no matter what your condition is, and you get to see somebody, and somebody's going to treat you. And oftentimes when I've gone to urgent care with a headache, I couldn't define it effectively, but I knew I had a headache, and I need somebody to help me. Well, many times the people, if you don't have a clarity of what mental health situation you're engaged in, you're either put through one door or that door, or you're pushed around or excused, and you're not seen as the whole person. So we need to really have effective psychiatric urgent care in parity with physical health care. One other thing that we find in the work that I do of breaking down barriers, my staff really say to me, these individuals, these families, these persons really want to see people who look like them. So the professional staff should be somewhat representative of the community they're serving. Recently, one of my staff was helping a woman who was having a mental health crisis, and they finally talked her into seeking help. We motivated her to go to this mental health care center, to be seen. We even talked to the individuals there so that everything sort of be aligned and ready for her. Once she got there, she's an African immigrant, was very frightened of the process, but she went in. When she went into the room with the doctor, it was a male. For African immigrants, females cannot be seen and work with males. So she got up, walked out, called my staff and said, "What did you send me there for? I have to be seen by a female." I couldn't tell him my problems. So it really was to naught. Yes, we had a service, but what did we do with it? Could we provide it for that person? We really have to know our communities. We have to have people who are representative of that community. We really have to ensure that we're being effective in what we're doing. So we have come a long ways in our mental health care and our array of services, and I don't want us to seem that we have not. Because in San Diego, I'm telling you, we got it going on in San Diego. We do wonderful work here. There's lots going on, but there's a lot more to do. So as we strive and as you develop these policies and practices and things, ensure that you keep the individual at the center of it and all the diverse communities of individuals that need to be at the center, and make sure that our services are truly effective. Thank you.
Hello, good afternoon. My name is Rebecca Hedman, and I work for San Diego Center for Children as a parent partner. Some of the struggles that I come across with these parents that I'm working with, first is, like a lot of people have been talking about today, is housing. Sometimes we can't even get into, well, let me first start with, for those of you who don't know what wraparound is, it's an individualized approach for the family where we go into the home as a team. My part is the partner with the parent, and then we have a youth partner or skills trainer that works with the youth. And then we have an intensive care coordinator or facilitator who is in charge of our team. It's a program that I'm very close to because I myself have been a recipient of this program on more than one occasion. But as I was saying, one of the biggest problems that they're facing is housing. So sometimes I go in with these families and I'm not able to even get to helping the parents concentrate on what is going on with these kids because there's nowhere, they don't have, housing for them to even, stable housing for them to live in. And then once we are hopefully finally able to stabilize the housing, another thing that we run into is that the parents themselves have mental health stuff going on and they are more of thinking, can you fix my child, instead of realizing that it's about the whole family. So we go in as a team and we try to integrate them into the field of trying to find family members, anyone, informal supports to help them feel supported so that when we come out of the home, they are still having a support system that can help to continue on. What makes, like I said, makes me a unique parent partner is that I, in fact, have been a recipient. I have an almost 14-year-old son who has a number of mental health diagnoses like Asperger's, oppositional defiance disorder, ADHD, and Tourette's. He has been a handful, to say the least, since he was very young. It was, for me, being a young mother as well, it was very hard for me to even know where to begin to start with my son. Before he was even 3 years old, he was diagnosed with ADHD because of severe hyperactivity and constantly being kicked out of childcare after childcare. By the age of 6, I received a phone call while I was at work saying my son had bit the principal 6 times and had completely destroyed an office room where they had gotten him to. I arrived to the school to see my 6-year-old hunched over with 2 police officers standing next to him. Not my finest moment as a parent. I didn't know what to do with my son at this point, and luckily I had a great counselor of the school give me a phone call and tell me that I should call the CPS, which I was unaware that I could call CPS for help for myself. And I asked for a volunteer social worker who began to help me receive the services. This was the first time I had wraparound with my son. I wasn't open to a parent partner the first time. But their services were helpful. Fast forward 6 years, my son once again was having constant problems, phone call after phone call from school, not knowing what to do with him once again, and he was starting fires. So I called the police and took him in and once again was able to get wraparound services. This time I did ask for a parent partner, and that was much more helpful for me because this time around I was a little bit more seasoned of a parent and was more willing to have help and was able to get more out of the services the second time around than I was the first time. Myself, however, I, as a child, experienced trauma, which was the reason for a lot of my bad decisions that I grew up. So I also have experienced mental health. I've been diagnosed with post-traumatic stress syndrome and depression. Growing up, for me, I was kind of the lost child, though. In school, I kind of suffered in silence. Nobody knew, nobody paid attention. I just did my work, and I'd go home and sit in my room. It later on caused me to make a lot of decisions that I should not have, leading me to then go on into using drugs. For 7 years, I used methamphetamines, and I'm proud to say that I have almost 4 years sober. Thank you. So one of my biggest differences between the first time I had wraparound and the second time I had wraparound was the first time I was an active user and the second time I was not. So that was also a reason why I was able to get more out of those services. Wraparound is an amazing program, and now from being on the other side of it, I'm able to understand even more than I did as the recipient. And I think that there's obviously more that can be learned. I feel like my passion recently has begun to move forward to trying to find a way to be an advocate for something that I've been feeling very passionate about, and that's trying to figure out how we can integrate mental health more into the school systems. I feel like being somebody who went through the system with schools and everything and being ignored, I feel like we have an opportunity to reach and do more prevention work through schools. These kids could be being taught at a younger age before they're going on to drug and alcohol problems, before getting guns and shooting. I just heard there was another shooting in Oregon this afternoon. I feel like if we can do more prevention work and reaching kids at a younger age in the elementary schools and teaching them how to deal with trauma, or if they haven't been through trauma, learn how to be more empathetic to those who have been through trauma. Life skills, social skills, we have math and English and all these other subjects that we have in the school systems, but there's no concentration on mental health. There's be much more prevention available if we could reach kids at a younger age. And then we have all these adults now who weren't taught these things. Kids are in schools more than they are with their parents. If you think about it, the 6 to 8 hours a day, 5 days a week. Society relies on parents to be the ones to teach their kids, which they should be, but if they weren't taught, how are they able to teach their kids? I wasn't taught these things. The first time I ever heard what a boundary was, a healthy boundary, and any of those types of terms was when I went through my outpatient care. So that to me is wondering why we aren't educating kids from a younger age and trying to avoid what now the adults are going through and people not knowing how to be socially appropriate. And so that's a passion of mine that I'm trying to look into figuring out how I could be more of an advocate for that. And I'm also pursuing a certificate in AOD, alcohol and other drugs, and then I'm going to go on to get a degree in psychology. So I just wanted to come up here and speak from an approach of not only a parent who's been through the system, but now a provider and also a recipient myself as being through mental health and the AOD community, and just kind of get that out there to everybody and hopefully make a difference in some way. So thank you.
Hi, my name is Melitza Jimenez, and thank you so much for having me here today. I am here today actually representing NAMI North Coastal. I have been affiliated with NAMI North Coastal for about 4 years, teaching the family-to-family class in Spanish. A little bit about myself. I have a master's degree from San Diego State University in rehabilitation counseling, and I am currently working at mental health system as an employment specialist. I am also a single mother of 2, and one of my daughters was diagnosed with a mental health illness about 6 years ago. I guess that qualifies me to be here today. I am here to share some of my experiences as a parent, but also to share some things that, in my opinion, are working. and some of the things that can be improved. I think that having a child with a mental health illness have been by far one of my biggest challenges, but also one of the most humbling and rewarding experiences. My daughter reminds me every day, and I'm sorry if I disappoint anyone here, that I know nothing about mental health illness. And she said, I don't want you to be my counselor. I don't want you to be my therapist. I just want you to be my mom. If I need help, she said, I ask you. I will ask you. And she did. Last time that she tried to hurt herself, she told me. She said, yesterday, I was thinking about hurting myself. And I had a plan. And she said, I use all my coping skills, but today you need to take me to the hospital. My daughter is now a 21-year-old, and he was diagnosed with mental health illness about 6 years ago. But I know that she started displaying mental health symptoms when she was in 4th grade, which I think were triggered by having a chronic skin disease and being bullied in school. I don't talk about mental health at home anymore because I know my daughter becomes very defensive about the topic, but she likes to read. So I bring home all kinds of pamphlets and reading material and leave them strategically placed where she can see them and read them. I'm here today not as an expert, but to share some learning experiences as a parent and as a mental health service provider, and my role of empowering, supporting, and helping my daughter and people with mental health illness become self-sufficient, independent, and reintegrate back into society, into their communities, by volunteering, going back to school, starting their own businesses, obtaining employment. I have to say that my daughter has been successfully employed for the last 2 years in a management position, which I'm very proud. So now I will describe some of my challenges as a parent and mental health provider and some of the things that, in my opinion, need some improvement. First, I have to say that when I received the invitation to participate in this forum, and I read the title, I was really excited to learn that we are, and I will say finally, taking a more broad approach and include the whole person rather than the illness. This is what I do every day, and as a parent and as a mental health service provider. Mental health systems, where I work today, allows me to take a biopsychosocial approach where I treat the whole person instead of their illness. And as a parent, NAMI Norcoastal has helped me to understand more my daughter as a parent, to communicate with her, to accept her and feel supported. As a parent and as a service provider, I have learned that individuals with mental health illness and their families respond well and recover well when they are educated, when they are empowered and supported. So some of the things that I will say are going well in terms of efforts of NAMI to eradicate the stigma, mental health illness, and their families. Also, the efforts of the Health and Human Service Department, the County of San Diego for their campaign, It Is Up to Us, that empowers San Diegans to openly talk about mental health, recognize their symptoms, and also utilize local resources. I also think that the Office of Disability Employment Policy, U.S. Department of Labor, which I think is doing a terrific job educating people about employing people with disabilities, the LEAD Center, the National Disability Institute, and also many other local organizations that provide mental health services. Obviously, there are a lot of resources in the community, but one of the challenges for most individuals with mental health illness and their families is why I am having such a hard time accessing services. And as a parent and as a service provider, I have to say that being a mental health service provider does not necessarily give me the lead, especially if you don't live in the San Diego area, where there seems to be more access to services and resources. I said earlier that we are doing a great job educating people about stigma, encouraging people with mental health illness to openly talk about their symptoms and to ask for help. I especially like how we are portraying people with mental health illness as just people like everyone else through the It Is Up to Us campaign. In my opinion, we have a great outline, but I think that people do not necessarily understand how, for example, mental health symptoms impacts an individual, cognitive abilities and functioning. I don't think people are aware that individuals with mental health illness, in fact, can recover and they can learn how to manage their symptoms. In my opinion, we need to focus more energy into helping them manage their symptoms, playing and maximizing their strengths, and to acquire the necessary skills that they need to move forward with their life, instead of trying to fix them or focusing on what they cannot do. I can tell you that as a mother, that my daughter can do a lot of things, and I know that. Because when everyone else was playing in the playground, learning social skills, how to communicate, interact with others, giving and receiving feedback, learning about playing rules, laughing, learning how to deal with acceptance and rejection, sharing personal stories, personal space, and learning how to be assertive, she was isolated, trying to figure out what was going on inside her head. I didn't have a chance to learn those skills necessary to have meaningful relationships, or to interact with others, or to pursue an education, or have a career, or seek employment. It is a humbling experience as a mother to realize that my daughter didn't do something not because she cannot do it, but because she does not know how to, or to realize that maybe she was able to do something before, but now she believes that she can do it until she learns or realizes how to do those things differently, maybe using another methods. I have learned that as a parent, in a way, and as a health provider, I tell my clients, I'm not here to tell you what to do. I'm here to guide you, to support you, and to provide you with the necessary resources so you can become self-sufficient and independent. I believe that, interestingly, most of the time the resistance comes from the individual's family about what they can and cannot do, and not necessarily from the individual. As a parent, I think that I have one more minute. As a parent, I have learned a lot of very valuable lessons from my daughter. And as a parent, as a service provider, I know that I have to be able to see everyone and treat everyone as a person who happens to have a mental health illness. And their mental health illness is not something that impacts their ability to do certain things. It's something that impacts them to do things in a certain way, but that doesn't necessarily define the person. I hope that you all agree that people with mental health illness want to be addressed as a person who happens to have a mental health illness, and not as their illness, because people with other illness are not addressed as their illness. People who have the right. People who have rights. I think that we can start by recognizing and treating them as people who have rights. I wish that you could see pictures. I wish that I can take pictures or take a videotape of my clients when I talk to them about ADA And when I tell them, do you know you have rights? And they don't know they have rights. I think that it's amazing what education and empowerment and support does for people. After all, who doesn't like to feel empowered and supported? I am glad that we are focusing more on the person, because I believe that focusing on the person is definitely a step forward in closing the mental health gap. Thank you.
Want to come up? No, you go. Do we have questions or comments for our panel? Apparently we do.
Yes, I will ask my question since Mary made me sit down earlier, you know. But I knew I would get a chance to come back and say something, but no problem, Mary. I'm Jim Gilmer. I'm president of MHA California, a member of REMCO, co-chair of the California Multicultural Mental Health Coalition, and former coordinator of the African American Strategic Planning Work Group. But I feel at home with this panel. I listened this morning of all the heavy policy decisions and, you know, the impetus to have more clinics. Someone said certified home clinics. I listened to even DHCS talk about the $150 million coming to counties. But I think this panel really embodies a lot of what goes on in urban, ethnic, racial communities. And you mentioned the Oregon shooting. Los Angeles had 19 shootings over the weekend. Just the definition of suicide and those types of things are very different in our communities and how people are taken out or choose to get taken out. So I'm wondering, with all the policy decisions and all the high-level discussions that have taken place here and will continue on, if the panelists can talk further relative to how can we embed reducing racial and ethnic disparities, much of the work that you've done and much of what's being planned and talked about today. If you can comment on things like that, I appreciate it.
Well, let me take a shot at that one. I think it's really important that we learn from each other and that we hear the voices of all. And many times the communities tell you the things that they need, and especially in ethnic communities, people will share. So as we begin to analyze what will be the best approach or strategy or service, it's the exchange of information, knowledge, and having all of us at the table to be able to shape the kind of services that we really need. I think by doing it that way, I think we can really make it effective in all our communities.
At IHOT, we had a Spirit Week recently, and part of our activities was to have a coworker speak about his life in the Philippines and share about the Philippines. And it was really fun. He shared personal stories. He shared some cultural aspects of the Philippines that I wasn't even aware of. So I felt like making learning fun in the workplace and learning even just about your coworkers is one easy way to become culturally competent in our practices.
One of the things that I didn't mention is I actually am bilingual in Spanish, and I work with the Hispanic families. And when I first come in, I'm a young white girl, so I get those looks. But once I get to know them and they see that I've invested in understanding their culture and getting to know the families on their level, it's very much appreciated by them. And then they're able to overlook the fact that I'm a white girl.
Thank you. Oh, one more, go ahead.
No, I will say that coming from a Latino culture, I think that I am really committed to work with NAMI in terms of teaching their familia class to educate the Latino community in terms of mental health illness. I think there's a huge demand in terms of educating people from the Latino culture in terms of mental health illness and what to do.
My name is Yvette McShann. I'm representing Victoria's Black Women in the CMMC, and I represent African American women and women of color. And I want to thank Delphine for mentioning providers that look like you. In African American culture, we really need that. And I never heard that spoken on a level like this. And I want to commend you on that because it's really needed. Because people do feel discriminated when they go in the office. They never seen nobody and have to tell them how they feel when they feel uncomfortable with the person that's in front of them. And even if you don't have a mental disorder, you'll feel uncomfortable just meeting somebody for the first time that's supposed to help you, and you're supposed to trust them and you're not sure. So I commend you for speaking about that. Thank you.
Thank you.
I just want to tell Daphne, who I know very well, that I came into this country at the age of 8.5 as an African immigrant. It just happened that I was born in Egypt, and the country from which I came from, which was Czechoslovakia at that point, their quotas were full. So my parents were asked where I was born, and they said I was born in Egypt. So nobody was coming over at that time from Egypt. Their quotas were empty. So I am now an African American for the United States.
Thank you. Go ahead.
I am Freddie Smith from Alameda County. One of the things as we talk about planning certified behavioral health care homes, maybe we also need to add the family component to that. We talk about having peers as a part of that. Let's also talk about how can we get family members involved in that. Because again, family members are going to be taking clients to those specialty referral services. And at the same time, if we want to make sure that those consumers get there, we need to have those family members there as well. Thank you.
And that criteria does require both peers and family partners.
And at IHOT, we do include the family. We have our wellness advocates like myself, but we also have family support partners that include the family and give classes and support groups. And then we also have care coordinators. So encourage everybody to always think of your family. They were one of the main factors in my recovery. So I agree.
One of the things that I've been recently involved with, I was approached by some African Muslim individuals about mental health in their community, because many of them are suffering from the fact that they didn't really understand it fully, and they didn't understand how to access it. It was not on their radar. And as well as the children being recruited through the internet to join groups that were unhealthy. So now we're engaging with them in a really unique way to understand what the Muslim community in San Diego might need and how do we provide services. So that's what I'm talking about. How do we get down to the belly of the issue and addressing real needs of real groups of people, not glossing over it, but understanding it and then providing quality services for them.
I want to thank you all. I think your comments have really helped ground us. You know, we can talk about policy and issues all day, but, you know, it's really about people. And it's diverse people in California, so we need to know that, or we don't do a good job. We're not effective. So join me in thanking them.